Welcome everyone to today's webinar on Milliken's Compression Training Academy. We will be covering Module 1, Venous leg ulcers and conditions affecting the lower limb. This is the first module of 6 in series. Follow-up information will be shared after this webinar on the dates and times for the upcoming modules. On behalf of Milliken, thank you for joining us. Before we begin, we'll touch base on some housekeeping. Today's webinar will begin with the presentation followed by a question and answer session. Questions can be submitted at any time during the presentation by clicking on the dialog bubble icon with Q&A noted in and entering in your questions. This webinar is being recorded and will be made available after the event on the Milliken Healthcare YouTube page. If at any time the slides stop moving or the audio stops, please exit out of the Microsoft Teams live event and rejoin. Please submit any technical questions that you have into that same Q&A icon, and we're here to help. Milliken & Company is a family-owned US-based organization in business for more than 150 years. With expertise in textiles and chemicals, Milliken's healthcare division was formed with innovative products and technologies focused around improving patient lives together. Milliken Healthcare offers a variation of products and technologies, including ones available for addressing venous leg ulcers. With that, I'm pleased to welcome today's speaker, Claire Stevens, Milliken's clinical nurse specialist. Thank you, Claire, for being here today, and I will turn the floor over to you.
Welcome to Milliken Healthcare Compression Training Academy, a series of educational modules intended for healthcare professionals caring for patients with leg ulcers and complications of the lower limb who require compression therapy. Welcome to Module 1. This module will focus on venous leg ulcers and associated conditions affecting the lower limb. We will explore lower limb physiology, clinical assessment, investigations, and leg ulcer differential diagnosis. This module will cover a background introduction to venous leg ulcers, including prevalence, cost to treat and recurrence rates, factors affecting the risk of developing chronic venous insufficiency, venous leg ulcers, and explore what impacts venous leg ulcer development may have on a patient's quality of life, normal venous and arterial blood flow of the lower limb, the venous system structures, and explore the complications that result in chronic venous insufficiency. Clinical assessment considerations, including investigations undertaken and differential diagnosis to distinguish between the characteristics of venous and mixed leg ulcers. Edema, why and how edema occurs in the presence of chronic venous insufficiency, and skin changes associated with chronic venous insufficiency. In preparing this presentation, we have used and relied upon information from public sources on the web. We therefore make no warranty, expressed or implied, as to the accuracy or completeness of the underlying assumptions, estimates, data, or other information not generated by Milliken. Venous leg ulcers are considered one of the largest healthcare challenges globally, requiring significant healthcare service provision through frequent medical appointments, recurring hospitalizations for complications, and multiple home care visits. Additional costs include disposable resources, such as dressings, bandages, creams, antibiotics, and many, many more. Venous are the most common type of leg ulcer, reported to account for 60 to 80% of all leg ulcers. The remaining 20 to 40% includes arterial, diabetic, chronic inflammatory disease such as rheumatoid, and those with blood disorders such as sickle cell, as well as post-traumatic and malignant leg ulcers. Venous leg ulcer prevalence rates are largely estimated, often quoted as being underestimated and well documented within the literature to increase with age. Prevalence rates also vary within the limited available published data from different countries. The United Kingdom estimated prevalence between 0.1 and 0.3%, whereas the United States of America has quoted approximately 600,000 cases annually, affecting 1.69% of their population. Also reported as being consistent with the observed rates in the European countries. The true cost of venous leg ulcer management, however, is still largely unknown and is described by leaders in the field as being significantly underestimated and significantly underreported in the literature. In 2017, Guest estimated the annual cost of managing a confirmed venous leg ulcers in the United Kingdom as being between £500 to £900 million. This was using 2013 to 2014 prices. Today, these figures alone would be significantly higher. The cost to treat a venous leg ulcer in the United States of America is estimated at being approximately $9,600, with annual costs estimated to fall between $2.5 and $3.5 billion. Again, these are reported as being in line with European costs, with Germany reporting a cost to treat a venous leg ulcer between €9,900 and €10,800. More recently, published in 2022, a cross-sectional prevalence survey from the United Kingdom, Irwin et al. Report figures in line with the literature. However, annual prevalence estimations and costs were found to be far lower than those reported in recent literature, suggesting that the costs of treating venous leg ulcers are perhaps lower than previously thought. The cost to the individual patient and impact on their quality of life is impossible to measure. Impacts will include pain, suffering, loss of income, impact on their wider family and friends, and social isolation. The average reported healing time of 12 weeks is considered to be a minimum, and in many cases, patients will experience venous leg ulcer wounds for many months and maybe even many years. Factors impacting their time to heal will include the wound duration, the episode, the size of the wound, the location of the wound, treatment regime, and compliance or concordance to the treatments that are being prescribed. It is important that patients receive and comply or concord to continued preventative care once their leg ulcer has healed. This includes continued good skin care, exercise, eating a healthy diet, and they must wear compression hosiery for life to prevent wound recurrence. Despite attempts to employ these measures and to prevent leg ulcer recurrence, Guest in 2018 reported rates of between 26 and 69% at 12 months post-healing. There are many evidence-based leg ulcer management and compression policies and guidelines available, some of which have aimed to establish a global consensus approach towards leg ulcer management and treatment selection. The International Advisory Panel for Compression Pathway, published in the European Wound Management Association compression document, aims to achieve the global consensus approach. However, there are national, regional, and local policies and guidelines which will impact the clinical decisions that you make and the compression intervention strategies that you make at local level. For many years, the standard definition for a venous leg ulcer has been a wound below the knee of 6 weeks or greater duration which fails to heal. This definition has more recently been seen as a potential delay to the commencement of either a timely investigation and consequently treatment, and therefore seen as a possible cause of delayed healing and increased risk of complications. Consensus opinion has more recently led to the reduction from a 6-week to a 4-week definition, published in 2010, redefining a leg ulcer as an open lesion between the knee and the ankle joint that remains unhealed for at least 4 weeks in the presence of venous disease. Again, in 2013, the National Institute of Clinical Excellence published a new guideline, thus reducing from 4 weeks down to 2 weeks, and this remains at 2 weeks in the current guideline. The updated definition being a break in the skin below the knee, which is not healed within 2 weeks. This is widely used within the United Kingdom and European countries, whereas the United States of America remain with the 4-week definition. There are many factors predisposing to the development of venous leg ulcers, and this list is not exhausted. Females are reported to be at higher risk of venous leg ulcer development than males, particularly females who have experienced multiple pregnancies and developed venous hypertension. Advancing age increases the risk in both male and female, as age-related changes affect both our arteries and our veins. Obesity, inactivity, or prolonged standing impacts the venous system, increasing the blood pressure within the veins. Limited ankle function, often related to inflammatory disorders, post-traumatic injury, or sports ankle injuries, restricts the ability to activate the calf muscle pump, which aids venous emptying and blood flow return. Those with a family history of varicose veins, previous leg ulcers, personal history of a deep vein thrombosis are all high risk for developing leg ulcers. Underlying diabetes predisposes the development of peripheral occlusive disease or inflammatory disorders such as rheumatoid, not only create a higher risk of leg ulcer development, but are well documented to also significantly disrupt wound healing. Several blood disorders have been identified as being causative factors predisposing to leg ulcer development, including sickle cell disease and clotting factor disorders. Some medications also carry cautions or are specifically linked to increased risk of either prolonged time to heal venous leg ulcers. For example, nicorandil, a medication for angina, now carries a specific warning regarding leg ulcers. How venous leg ulcers affect the individual is a very personal experience, and this list is not exhausted. Cost to the individual is both in monetary and social form. The patient may lose income or have to change their career completely. For example, in hospitality or catering, where open wounds will pose a health risk, they may lose their role. Income is reduced. Combine this with increased costs for care, appointments, medications, and insurances. As a result, other family members may also be affected, such as the patient no longer being able to support a child's educational or recreational activities and needs. Social isolation is very common in leg ulcer sufferers. They may not be able to share a bedroom with a spouse or partner due to fear of wound leakage and odour concerns. They may be unable to undertake activities that once were their social calendar. This may result in loss of friends and other relationships outside of their home and can lead to lower mood and deeper social isolation. Venous leg ulcers can also be extremely painful, often resulting in a chronic pain syndrome, which have huge impact on the person's ability to cope. Quality of life publications consistently report pain as the person's most significant impact, closely followed by wound drainage and leakage. Venous leg ulcer wound fluid leakage combined with the need to wear compression bandages for several days can often lead to malodour or smell. Individuals often feel they need to lock themselves away as they are too embarrassed someone may be aware of their odour. They may avoid public transport or public places. Eventually, their only trips out may be to have their dressing and bandages changed. Fluid management to prevent leakage is one of the biggest challenges in managing venous leg ulcers. Unmanaged wound fluid puts the wounds at high risk of becoming infected and also creates additional skin complications such as maceration and increase the size of the wound margins. The patient may also damage clothes, footwear, carpeting, bedding as a result. Body image can also affect in so many ways. Individuals may wear old clothes due to potential damage, baggy clothes to cover the dressings and bandages. One leg may look significantly larger than the other. They are unable to wear their normal clothes and footwear. In quality of life studies, individuals report a loss of their self and a loss of their identity. Sleep deprivation, mostly possibly due to the chronic pain and fear of wound leakage, also impacts the mood and the patient's ability to cope with the pain, ability to function generally, and will heavily impact on any wound healing progression. It is important to take a balanced diet to aid wound healing, and additional nutritional support will be required for those with highly exuding wounds, such as increased protein levels. A loss of appetite often results as a result of pain, odour, leakage. Depression and sleep deprivation will all significantly impact the progression towards healing. Holistic assessment and the importance of addressing and supporting patients' quality of life improvements are absolutely paramount. We are now going to explore normal blood flow of the lower limb and look at what can go wrong. The images that you can now see demonstrate the importance of blood flow, and when we intervene with treatment regimes, the importance of getting it correct or the consequences of not. Lower limb blood flow is comprised of two types of vessels: arteries, which are the strongest vessels transporting oxygenated blood rich of nutrients from the heart to the tissues, and veins, which are vessels lower in strength to the arteries and carry deoxygenated blood away from the tissues back to the heart for replenishment. Arterial insufficiency, peripheral arterial disease or peripheral occlusive disease, commonly seen in diabetic patients, occurs when the flow of blood through the arteries is reduced, restricted or obstructed due to atherosclerosis. Atherosclerosis is deposits of plaque containing cholesterol, a fatty substance, cellular waste products, calcium and fibrin. As the plaque builds up, the wall of the blood vessel thickens and the chamber for the blood flow narrows, reducing the volume of oxygenated blood and nutrients able to reach the tissues. As the severity of plaque increases, the risk of tissue destruction increases, and in the most severe cases can lead to digit or limb amputation. Assessment of underlying arterial insufficiency is a critical decision-making factor when considering the use of compression therapy and the safe level of millimeters of mercury pressure to prevent further vessel occlusion. The venous system has three structures all working together: the veins, the valves, and the calf muscle pump. Chronic venous insufficiency can be a result of failure of one, two, or in most common cases, all three of these structures. Firstly, we will look at the veins. There are three types of veins which are all interconnected and work together to help facilitate the return of deoxygenated blood away from the tissues and back to the heart for replenishment. The deep veins, which are located within the musculature, the superficial veins, which are located within the subcutaneous layer of the skin, and the perforator veins, also known as the connector veins, which connect the deep and the superficial veins. If blood pressure becomes too high within the deep vein due to perhaps prolonged standing or pregnancy, this will eventually impact the pressure within all three interconnected veins, leading to vein wall damage. The valves within the veins also play a critical role in aiding venous return and preventing backflow, also known as venous reflux. Image 1 demonstrates a healthy, competent valve. The cusps are opening and closing, allowing blood flow back to the heart whilst preventing a downward or backflow as the valve cusps close. In image 2, we can see an unhealthy, incompetent valve. We can see the damage that prolonged high pressures within the vein has caused. Firstly, we can see that the walls of the vein have become weakened, buckled and ballooned under the stress of the high blood pressure. And secondly, we can see the damage to the cusps of the valves, and the ballooned area of the vein is now preventing the valve cusps from meeting to close correctly. This blood flow is now compromised. The flow back towards the heart is squeezed back through the incompetent valve, and venous return cannot be achieved. The calf muscle pump is the final structure in the venous system. The calf muscle, when activated, provides a squeeze against the deep vein to aid upward blood flow and venous return. Patients who have a wasted calf muscle or a fixed ankle joint, and those who are unable to dorsal flex or move their toes, become unable to activate this system effectively. One of the key functions of compression therapy is to support the calf muscle pump to help to empty the deep veins. As a result of compromised venous return and edema flooded tissues, limb and skin changes will occur. The clinical signs of chronic venous insufficiency include tired, aching legs and mild limb swelling. These can be the first signs that you have chronic venous insufficiency. The limb swelling or tissue edema will start off as being very mild, and the swelling to the limbs will increase over time as the severity of the chronic venous insufficiency increases. Newly developed varicose veins are an indication that the veins are under high pressure and the vessel walls have become weakened and are ballooning from the pressure. Left untreated, eventually edema will lead to tissue and skin breakdown, known as venous stasis ulceration. There are many superficial skin changes which may occur. Firstly, skin discoloration. You may get red or brown staining patches known as hemosiderin, and secondly, texture may change, dryness, flaking, itchy, eczema. There also may be tissue hardening and the skin may actually feel leathery. There are many leg ulcer policies and guidelines available globally, aiming to achieve a consensus approach towards assessment and care pathways for patients with leg ulcers. Their aim is to provide evidence-based care consistently to ensure safe, accurate practice and optimise patient outcomes. The International Compression Advisory Panel is a collaboration striving for global consensus and published their recommendations and pathway in the European Wound Management Association Compression Therapy document. Despite there being a goal to achieve this international pathway and consensus, many other policies and guidelines do exist. which will impact treatment pathways, clinical decisions and therapy choices for leg ulcer management. National guidelines such as the National Institute of Clinical Excellence guideline for the United Kingdom, regional guidelines for specific geographical areas, or healthcare service providers and local guidelines specific to individual hospitals or leg ulcer services. One example might be the lower and upper limits on an ankle brachial pressure index. These may be different in an international document than within a local guideline. As an additional precautionary measure, it is important to have sight of all policies and all guidelines that are relevant to your practice. Disparity in approaches to leg ulcer management in terms of when to initiate treatments, for example, ankle brachial pressure index, upper and lower limits may vary and affect treatment decision making, particularly compression, type and level. The importance of a full holistic assessment is paramount before looking at the limb or the wound. A full general medical history is required, and any personal history of a deep vein thrombosis or previous ulcer history plus family history of varicose veins. Medical conditions such as diabetes, inflammatory or blood disorders such as rheumatoid or sickle cell, trauma injury and any medications the patient is currently or has been taking. Lifestyle considerations including activity level, high impact activities, work role, and if standing or driving for long periods of time, frequent flying, stress, smoking, recreational drugs or alcohol, which are all known to predispose leg ulcers and delay wound healing. Dietary considerations to include obesity or emaciation, and significantly a dramatic increase or loss of body mass over a short period of time. Wound history, episode of that wound, duration of that wound, location, and any current treatments or dressing regimes should be captured. The limb and wound can now be examined. It is important to establish lower limb blood flow status and investigate for underlying arterial insufficiency. A Doppler ankle brachial pressure index, also known as an ankle brachial index, is the most commonly used non-invasive assessment tool used to calculate arterial insufficiency level. For the purpose of this module, we will refer to ankle brachial pressure index. Factors affecting choice of assessment tool will include the level of pain and the ability to inflate a blood pressure cuff without causing additional pain for the patient, the level of edema and the ability to establish an accurate reading with a Doppler probe, the location of the ulcer, that it's not located somewhere where the blood pressure cuff needs to be placed. This can be covered to facilitate assessment, but pain does need to be considered. A rest period is required, usually 30 minutes prior to undertaking an ankle brachial pressure index. And for patients attending clinic appointments, this is often challenging to achieve and may result in an inaccurate reading. Inability to gain a reading or locate a pulse due to edema or finding a faint pulse. A borderline result may be obtained, which requires a more robust assessment method to establish if a treatment regime is appropriate or not. Overriding clinical judgment if a limb appears to have arterial indications, but the ankle brachial pressure index does not reflect this. Combined investigations have become increasingly popular. For instance, ankle brachial pressure index and duplex scan. There are newly developed devices available on the market which measure and automatically calculate ankle brachial pressure index. We will explore how a manual Doppler ankle brachial pressure index reading is undertaken and the calculation of the brachial and ankle blood pressures to generate the ankle brachial pressure index reading. Both arms are used to take the brachial pressure, and dorsal pedis and posterior tibial pulses on each foot. The highest ankle pressure reading is divided by the highest brachial pressure reading to give a pressure index calculation. The illustrated pressure index chart can be used as a quick and simple index calculation tool by following the axis down and across for the ankle and the brachial pressures, and where the axes meet, the ankle brachial pressure index will be revealed. The ankle brachial pressure index reading can be interpreted and aligned to appropriate therapeutic compression interventions. An ankle brachial pressure index greater than 1.3 indicates a calcified vessel or possible arterial occlusion, and the patient must be referred to a vascular consultant and is not suitable for compression therapy. An ankle brachial pressure index greater than 0.8 to less than or equal to 1.3 indicates mild to no peripheral arterial disease, and standard compression can be used, recommended at 30 to 40 millimeters of mercury pressure. An ankle pressure brachial index greater than 0.5 to less than or equal to 0.8 indicates moderate peripheral arterial disease, and light compression can be used, recommended at 20 to 30 millimeters of mercury pressure. An ankle brachial pressure index less than or equal to 0.5 indicates severe peripheral arterial disease, and the patient must be referred to a vascular consultant and is not suitable for compression therapy. Other tools that may be used to assess blood flow are pulse oximetry, which measures oxygenated hemoglobin levels or oxygen carried by the red blood cells in pulsating vessels. This is often used following the application of compression to ensure that blood flow has not been disrupted. Not a reliable method for patients who have severe edema or are peripherally shut down. Duplex scan has become increasingly utilised and accessible as a more accurate assessment of blood flow. A duplex scan uses ultrasound sound waves to produce images of the blood vessels and blood flow. The duplex images are able to provide a more comprehensive assessment by showing blockages in arteries and veins, the vessel size and shape, and problems within the valves, and is deemed a more reliable tool. There are different types of venous leg ulcers. Those with an ankle brachial pressure index of greater than 0.8 to equal to or less than 1.3 are venous leg ulcers. Those with mild or no underlying arterial involvement and are suitable for standard compression, 30 to 40 millimeters of mercury pressure. And those with an ankle brachial pressure index greater than 0.5 to less than or equal to 0.8, which are mixed venous. These have an underlying mild to moderate arterial involvement and are suitable for light compression, 20 to 30 millimeters of mercury pressure. Arterial leg ulcers are outside of the scope of therapeutic compression and must be referred for vascular assessment and management. Venous leg ulcers are usually accompanied by moderate to severe levels of edema. They are located in the gaiter area of the lower limb, which is between the ankle and the mid-calf. They are often large wounds with multiple other satellite wounds which often join and enlarge the main wound. It is not uncommon for venous leg ulcers to become circumferential or wrapped around the entire limb. The wounds are usually shallow with irregular, gently sloping edges. Venous ulcers are often longer duration wounds, also known as chronic wounds, and may contain several different tissue types, including granulation, slough, and be covered in fibrin. They're also known to exude moderate to high volumes of wound fluid. Chronic wound fluid varies considerably in its colour, consistency and microenvironment, which can be destructive to the skin and inhibit cell growth and movement. Infection is very common in venous leg ulcers. Pseudomonas infection is particularly prevalent. Due to the duration of the wound and the levels of fluid leakage, these wounds often tip into clinical infection. These patients are also at high risk of cellulitis development. Pain is often associated with the edema, inflammation or infection and the treatments being used. Pain is usually relieved through limb elevation. Mixed leg ulcers are usually located at the ankle and the lowest aspect of the gaiter region, with mild to moderate volumes of edema. Wound size and shape is variable, often smaller and deeper than the venous ulcer. The wound edges are rolled, smooth and semi-punched out appearance, indicative of underlying arterial insufficiency. The limb and wound tissue is pale and prone to developing devitalized tissue or slough and necrosis. Wound fluid levels are lower than with a venous ulcer, usually low to moderate levels, and infection is also common. The patient with mixed disease is unable to relieve their pain with limb elevation or through dangling their limbs over the side of the bed due to arterial and venous involvement. Edema as a result of chronic venous insufficiency is commonly one of the first signs a patient will notice prior to the development of any notable skin changes or ulcer development. Edema is defined as clinically apparent increase in the interstitial fluid volume, which develops when Starling forces are altered so that there is increased flow of the fluids from the vascular system into the interstitium. Edema may be caused by venous hypertension, chronic venous insufficiency, history of deep vein thrombosis, post-thrombotic syndrome, phlebitis, trauma, or severe varicose veins. Moffat et al. In 2003 state that edema present for more than 3 months is said to be chronic edema. The gold standard treatment for edema is compression therapy. Prolonged untreated edema will result in further complications to the skin, increasing the risk of infection and cellulitis, fluid leakage, and ulcer development. Edema will initially present as soft within the tissues, often called pitting, remaining indenting after pressing, but will also reduce when the limb is elevated. Prolonged untreated edema will result in an accumulation of waste products within the tissues and hardening of these tissues over time. Eventually, severe hardening will occur, which results in fibrosed tissue deposits, which is very challenging to manage and cannot be reversed. Compression therapy used in the early stages will effectively treat edema and prevent chronic edema. Displacement edema may also occur as a result of poor compression therapies or techniques. If a patient's lower limb has been reduced by the use of compression, but the edema has now moved from below limb to above the knee, now over knee and thigh-high bandage will be required. Skin changes associated to chronic venous insufficiency include hyperpigmentation, also known as hemosiderin staining. A brownish red tissue staining is caused through leakage of blood through the capillaries, pooling beneath the skin, leaving hemoglobin residue in the tissues. Venous or gravitational eczema occurs due to edema waste products becoming a skin irritant. Patients may present with itchy, red, scaly, flaky skin, or may have more severe forms resulting in pustules, blisters, and crusts. Lipodermosclerosis is an extremely painful complication whereby the skin becomes hardened and very taut. Atrophy blanche, also referred to as heart attacks of the skin, are clusters of small white star-shaped atrophic scars which usually appear in areas where pigmentation or staining is present. In summary, following this module, you have gained knowledge on the prevalence or size of the venous ulcer problem and associated costs, multiple risk factors associated to chronic venous insufficiency and leg ulcer development, the impact of leg ulcers on a patient's quality of life, the arterial and venous systems, and what has gone wrong for chronic venous insufficiency and leg ulcers to occur, how to recognise the clinical signs of chronic venous insufficiency, that many different policies and guidelines underpin our leg ulcer care pathways, how ankle brachial pressure index is measured and readings interpreted to plan care pathway, differential characteristics of leg ulcers and associated edema, how to recognise skin changes associated to chronic venous insufficiency. Thank you for completing Module 1, Venous Leg Ulcers and Conditions Affecting the Lower Limb of the Millikan Healthcare Compression Training Academy. There are 5 additional modules in the Compression Academy series. Module 2, Understanding Compression Therapy, explores how compression works, the theory and science of compression, compression types, characteristics of an ideal compression, selection of compression and patient benefits. Module 3, Compression Therapy in Practice, explores and compares various bandage materials, application methods, ease of use, ease of training, patient safety and competency, how to correctly apply, how to achieve desired levels of compression. This module includes compression frequently asked questions and a training competency framework example. Module 4, Wound Management Principles with Compression, explores best practice skincare, wound care, exudate management, infection management and prevention strategies combined with compression therapy. Module 5 supports home care practice, patient information and patient care advice materials for looking after compression at home, preventing recurrence, skin management, diet, exercise and hosiery. Module 6 provides clinical evidence summaries to support your compression practice and how to set up and run a clinical evaluation with data template examples.
Thank you, Claire. That was a great presentation. Attendees, we will now begin today's question and answer session. Millikan's clinical nurse specialists Gwen McComey and Susan DeBack are here to answer your questions. We have approximately 15 minutes remaining within this time block. Again, you can submit your questions by clicking the Q&A dialog bubble icon within the Teams console and type them in. So we'll begin with this first question. Gwen, I'm going to pass this first one over to you. How frequently should an ABPI assessment be undertaken during a patient's treatment pathway? And Gwen, you may be muted, so if you are having challenges or difficulties, Then I may pass this one over to Susan. So how frequently should an ABPI assessment be undertaken during a patient's treatment pathway? Gwen or Susan, are you on the live event and able to answer the question? Well, why we try to wait and see if they're able to join. As you all know and are probably familiar with doing virtual events, there's always the potential for technical difficulties. But I would like to mention that at the end of this webinar, the recording will be provided and available on the Millikan Healthcare YouTube website. There will also be a post-webinar survey, and we would love to get your feedback on how you enjoyed the content, ways we can improve, things of that sort. We also have listed on this slide a link to the Millikan Healthcare website, as well as the Millikan Healthcare email, where if you come up with any additional questions or questions that we haven't been able to answer during this session, please feel free to reach out. So we've got the email and a survey link for this webinar, and we would just love to get your feedback. And again, I want to thank Claire for taking the time to walk us through this wonderful presentation, and for also you attendees for taking time out of your busy day to join this education session hosted by Millikan. And Tracy has also added into the actual webinar conversation section a link to the second session for module number 2, as well as the link to the post-webinar survey where we'd love to get your feedback. And the answer to the ABPI question, Claire's been able to provide an answer within the actual Q&A response portion, but I will read it off to you. So an ABPI assessment is initially undertaken to assist the diagnostic phase and should always be performed prior to commencing any compression therapy. ABPI should also be undertaken if there are significant changes to the patient's general condition, if the wounds fail to heal or start to deteriorate, and on an annual basis upon healing for purpose of using the correct class of compression hosiery. There is a wealth of published evidence supporting increased incidence of arterial involvement with age, and changes can occur within 1 year, tipping a patient from venous to arterial. So hopefully that answers your question. Okay, well, like I said, thank you so much for attending this Module 1 of Milliken's Compression Webinar Academy. We've included a link for Module 2, and we hope that we'll see you there. Again, this is a series of 6 modules. We've provided the website and email link for any further questions that you may have, and we hope that we can answer them. We'll see you all at Module 2. Thank you so much.